So de-resuscitation. De-resuscitation is defined as the active removal of fluid in patients with clinical evidence of fluid overload using either drugs or using ultrafiltration. The term was coined in 2014. When we start the de-resuscitation process, one approach is to answer 4 key questions, starting with when to initiate de-resuscitation. The answer to this question is when there is a clinical evidence of fluid overload suggested by worsening hypoxia, worsening renal function, raised intra-abdominal pressure with evidence of positive cumulative fluid balance. This is substantiated further by bedside ultrasound or other investigations. Ultrasound is especially useful in picking up B lines or pleural effusion on lung ultrasound, or evidence of systemic congestion with the use of venous access ultrasound. One thing is clear, that patient must be hemodynamically stable when we initiate de-resuscitation. Second question is how to initiate the de-resuscitation process. Loop diuretics like furosemide and torsemide plus or minus acetazolamide are probably the most widely used de-resuscitation strategy. In patients with oliguria or anuria, ultrafiltration using CRRT or SLAD may be useful. One suggested approach is to use 40 milligram bolus of furosemide followed by furosemide infusion, which can be titrated up to 40 milligram per hour. A strategy of using hyperoncotic albumin, either as bolus or as infusion, is suggested and shown to increase the total volume of fluid removed without causing hypovolemia. Another approach suggested in patients with raised intra-abdominal pressure is to use a combination of positive and expiratory pressure matching the intra-abdominal pressure of the patient, along with albumin and Lasix. Lasix is the commercial name of furosemide, a strategy which is also called the PAL strategy. It has shown to reduce the extravascular lung water significantly compared to a more standard strategy. Third question is how to monitor the de-resuscitation process. Of course, one aspect of monitoring is whether our strategy is efficacious or not. One suggested strategy is to achieve a negative cumulative fluid balance or negative balance of more than or equal to 1 ml per kg ideal body weight per hour. Else, a more easier strategy is to look for the reversal of systemic congestion on VACs or disappearance of B lines, which clearly suggests that, okay, de-resuscitation process is getting helpful. We also should look for evidence of any adverse consequences of de-resuscitation suggested by evidence of hypovolemia or tissue perfusion, hypoperfusion of tissues, or any adverse effects of diuretics itself. For example, patients with evidence of hypokalemia, hypomagnesemia with cardiac arrhythmia, thrombocytopenia, agranulocytosis, pancreatitis, Stevens-Johnson syndrome, toxic epidermal necrolysis, which are rare side effects of loop diuretics. Final question to be answered is when to stop de-resuscitation. Of course, de-resuscitation should be stopped when the target is achieved. That means patient has shown significant improvement in the organ function along with negative fluid balance. For example, a patient who is weaned off from the mechanical ventilator after achieving the negative cumulative fluid balance. Or if there is any evidence of hypovolemia or organ hypoperfusion, in that case, even sometimes judicious re-administration of fluid is required, followed by restarting the de-resuscitation process at a lower rate. So this is, in summary, how we can and do a de-resuscitation process successfully.